你那个有退得到吗？
我还没，
你要记得
我还没去。
7天哦，因为它通常是7天内。
好的，
如果不行，你再跟我说，我再把钱给你。
好的。
So this is the 81-year-old female. She had a clinical impression of a transverse colon cancer with obstruction, and this is her ascites specimen. So it seems to be that the patient already developed advanced stage disease and difficult to do operation. So in this ascites specimen, the cellularity is relatively scant, and we do see quite some atypical cells. Majority of these atypical cells were single cells. For example, like this one, it seems to be binucleation, and the nucleus is pretty big. The chromatin is relatively vesicular, and there's some nucleoli. So here again, we can see some of these loosely cohesive single cells with a bizarre shape of but prominent nucleoli. So these cells are suspicious for poorly differentiated adenocarcinoma. So sometimes these type of single cell, it's relatively difficult to make distinction with reactive mesothelial cells versus poorly differentiated adenocarcinoma. I think some of the most important clue is that first is unequivocal nuclear atypia, which include big nucleus, prominent nucleoli, and sometimes the cytoplasm and the cell border can show these double layer type of feature which are overlapping between the mesothelial cell and the poorly differentiated adenocarcinoma. So these double layer cell contour is not specific for mesothelial cell. So these needs to be addressed. The other thing is that if you do see the cell with prominent eccentric arrangement of the nucleus, and it is more likely to be a poorly differentiated adenocarcinoma than a reactive mesothelial cells. Finally, occasionally you were able to find some loosely cohesive cell cluster. So these may represent several cells aggregates together arranged in a three-dimensional, like a small abortive glandular type of pattern. So this is also diagnostic for adenocarcinoma. So for this case, this is a colon cancer, but it does not show the usual type of feature such as like intestinal differentiation, pseudostratification, glandular structure, but relatively poorly differentiated with these type of like eccentric nuclear type of feature. Okay, so this is still diagnostic for poorly differentiated adenocarcinoma. The next specimen is a CSF specimen. So the patient do have history of adenocarcinoma. We have signed out her prior CSF as positive for adenocarcinoma coming from the lung. So whenever we interpret CSF specimen, it's very important that we know the clinical impression, clinical history. So if the patient has sign of meningitis, and then you will see some inflammatory cells. But for this patient, she had lung cancer and has been confirmed to have leptomeningeal spreading. So in this situation, even a single cells looks like this is very atypical. So in this specimen, the cellularity is very, very low, which is quite common for majority of the CSF specimen. But because you see these epithelioid single cells, this is still diagnostic for adenocarcinoma. So sometimes in these CSF specimens, the metastatic tumor may not show striking nuclear atypia. But if you go to higher power, I think the nucleus is big. The shape of the nucleus is strange. It looks like a kidney, and the Renzi ratio is relatively high. So this is still consistent with metastatic adenocarcinoma. So the second specimen is a pleural effusion specimen coming from an 81-year-old female who has history of adenocarcinoma with EGFR mutation under tyrosine kinase inhibitor. So she developed pleural effusion during the treatment. So in this specimen, in the background, you can see inflammatory cells, maybe some mesothelial cells or histiocytes. However, in between, we do identify a few atypical cells with relatively increase in the size of the nucleus, as well as sometimes with a little bit of cytoplasmic vacuole. So this is a cell with multinucleation. These could be reactive. These are cells with eccentric nucleus, a little bit bubbly of the cytoplasm, but this type of cell is very, very, very scant, very scant. And here we have a few binucleated cells. It looks a little bit larger than the adjacent, these normal looking cells. So I think for this case, it's kind of difficult to determine whether these are reactive or true metastatic adenocarcinoma because the feature is very indistinct. So the patient also had a cell block preparation. There's nothing over there. I think overall with this background, it seems to be still reactive, but if we want to make sure, we can do a TTF1 stent. So we will do the stent for this case and do a TTF1 stent. Because the patient is known to confirm to have cancer, so the main reason for that to do this is to confirm if there is any like a drug-resistant recurrence of the disease. So for this case, it would be very difficult to do the molecular test, and these might be representative of a very early stage of the recurrence. Yeah, so if we want to make sure, we just do a TTF1 to see if these will be positive. Just by the morphology, it is equivocal. So if we don't have any material left, we might probably call this atypical. And they can keep following the patient, and if it still has the pleural effusion, they can send it again. So occasionally we will encounter this type of situation that is difficult to have a definite call whether this is reactive or this is metastatic. So the next case, again, history of lung cancer and under the treatment of EGFR, and so it's very similar. Just in the cytology, cytospin preparation, we do not see any atypical cells, only the inflammatory cells and some reactive like mesothelial cell in the background. However, in the cell block preparation, there is one single like a focus showing like this. This looks like adenocarcinoma. So it's getting a bit difficult because there's only one focus. So we need to realize that during the treatment, they might develop early recurrence, and sometimes the tumor cellularity is very low. So I think for this case, because it appeared to every section, so it's still likely coming from the patient, although it is at the edges of the cell block. So we would still do a TTF1, do a recut TTF1 to see if there were anything else, if there were something more. And if there is nothing more, I think we might probably use suspicious for this case. Yeah. It looks like an adenocarcinoma, but because only the single focus attaching to the edges, sometimes floater can also look like that. So I think for because there would be a significant change of the treatment, so we need to be 100% sure for this condition. So the next, we go to the fine needle aspiration. This is a touch imprint cytology from a core needle biopsy of a 67-year-old female. Clinically, she had a mass over her breast. For 5 years, she didn't want to go to the doctor to deal with that. And then she developed a lung nodule, so she received a core needle biopsy of the lung nodule. So this looks like a non-small cell carcinoma. On low power field, we can appreciate that they do showing some glandular type of cohesive arrangement. However, there are also some of these like a single cells, more oval shape, more like a spindle shape with some cytoplasmic process, a little bit spindling, looks a little bit like squamous cells. Especially the chromatin pattern seems to be more hyperchromatic than vesicular. So whenever you see a glandular type adenocarcinoma, cells with a squamoid type of feature, the most common origin would be coming from the breast. So the breast ductal carcinoma will have these very frequently have these squamoid type of feature, which including hyperchromasia and cytoplasmic process. So based on the morphology, this is a non-small cell carcinoma, but if the patient do have an invasive ductal carcinoma, I think this is more likely to be a metastatic breast cancer than the primary lung cancer. Okay. So then we move to thyroid aspiration. So this is a classic case. On low power field, we do not see a lot of colloid. We see it's cellular. We see some like a monolayer, larger sheets. And we also see some more like a branching type of papillary architecture. So this looks like PTC just under low power. So whenever we suspect PTC, we need to go to higher power. So in high power, you can appreciate that the cells are oval shape. The axis is crossing with each other, is disorganized, and we do see a lot of grooves. So it looks like coffee beans. So almost every cell has at least a typical type of feature. So this is consistent with the papillary thyroid carcinoma. So here we have a luminal border, and this is more like a tall cell feature over here. So a few areas showing a little bit of tall cell type of feature. So here we do see a pseudo inclusion. So this is consistent with a classic papillary thyroid carcinoma, likely a BRAF mutated one. So we have two other thyroid aspiration. So this is the first one. So the first one, on low power, first of all, we do not see colloid. On high power view, we see a lot of these relatively atypical looking cells with big nucleus, some with prominent nucleolus, but the cytoplasm seems to be quite plenty with a granular, densely granular type of feature. So these cells are oncocytes or Herzl cells. So in this specimen, we see majority of the cell composition are Herzl cell with a little bit atypical features. Whenever we see a Herzl cell oncocyte reach aspiration, we need to pay attention to the background, whether it contains a lot of colloid or if there is a lot of lymphocytes. In this case, it seems to be like background showing quite prominent lymphocytic component, as well as a plasma cells. So if we have a combination of Herzl cells with a lot of lymphocyte, despite the nuclear atypia, it is still likely a result of a Hashimoto thyroiditis. So whenever you see the feature like these, we will go to the clinical information to check if there is increase in the serine anti-TPO autoantibody. So the patient do have a very high anti-TPO level. So this is consistent with a Hashimoto thyroiditis. Okay. If there is no lymphocytes or no colloid, for this case, it's likely that we will call this suspicious for oncocytic tumor. If we do see colloid, it's likely just follicular nodule disease with focal Herzl cell oncocytes. And if we have a few colloid or a few lymphocytic cells, and we don't have any data for the serine marker, and it does show some nodularity in the image, we might call these AUS with oncocytic aspiration, Herzl cell aspiration. Okay. So the next thyroid aspiration, so for this specimen, the cellularity is lower than the prior case. And in the background, we also have some oncocytes. But these oncocytes are relatively not so polymorphic, atypical than the prior case. So in the background, it seems to be a few inflammatory cells, but the patient do not show elevated anti-TPO. So for this case, it's a little bit debating between that, should we call these AUS with oncocytic aspirate, or should we call these benign? Because of lack of colloid, there must be some reason showing that lack of colloid type of pattern. And so for this case, we do see quite some multinucleated giant cells. So there is one over here, suggesting that the patient might still have a thyroiditis. We have a couple more somewhere else. So for this case, I think it is likely a subacute thyroiditis because of these degenerative type follicular cell changes, inflammatory cell in the background, and some multinucleated giant cells, but lack of elevation of anti-TPO. So for this case, because of the presence of multinucleated giant cells, we will call these granulomatous thyroiditis The clinical impression is also thyroiditis, but in focal area, it shows some radiologic findings suggest that it might be a microcalcification. So the patient came to our hospital for the aspiration. But I guess for these, either they missed the lesion or it's just a presentation of subacute resolving subacute thyroiditis. So the patient might be followed for a couple months to see if the lesion was still there. If it is still there, it can still to do a repeat aspiration. But so far, we do not see anything suspicious for papillary thyroid carcinoma. So we call these negative granulomatous thyroiditis. So we have 2 thyroiditis cases today. So that's for all. Thank you. 通常我们在 uncle side 的 case 的话，我们不太会看到 micro， 因为就是说它细胞就是它的 follicle 会 collapse，所以应该是 micro follicle， 可是因为它是 uncle side。